ICD therapy in long QT syndrome. Let me stress that we have some disclosures. We have some research ongoing under funding from Boston Scientific, Biotronic, Livanova, which produce defibrillators. And I have been in some consulting for Abbott and Medtronic that produce ICDs. Speaking about therapies, we already spoke about number of measures. I would like to stress that we are very much emphasizing importance of preventive measures like lifestyle modification, avoiding QT prolonging drugs. And we heard today a lot about anti-adrenergic therapy, which means beta blockers mostly, but also left cardiac sympathetic denervation, which was mentioned a couple of times today by Dr. Goldenberg as another option to decrease kind of catecholaminergic stress-related response of the heart. There is also gene-specific therapy, obviously, and these two examples of mexiletine and flecainide could be applied to some patients. Pacemakers are used, but used less frequently as individual therapies. And at the bottom of this list is ICD, implanted cardioverter defibrillator. I put them in the bottom because they are usually considered as kind of last resort. If we speak about defibrillator, you are probably familiar with automatic external defibrillator. You may see them at the airport and malls, probably not now, but when we used to travel, and they are effective in reducing risk of mortality associated with cardiac arrest. But obviously there is option of implantable device. Implanted device, which could be going with the wires to the heart on the left on this slide, and there is this generator which eventually produces current defibrillating this heart. And there is another option which is so-called subcutaneous under the skin without need to access the vein and heart, which could be considered too. Want to stress, because we spoke today about Dr. Moss, who established International Long QT Syndrome Registry. Also, he contributed enormously to the field of implanted cardioverter defibrillator therapy. And here is a picture of Dr. Moss together with Dr. Michel Mirowski and Morton Maurer, who were two inventors of implanted defibrillator. And Dr. Moss, from early age of this development, was involved and later on conducted really seminal clinical trials along the line. How this defibrillator works? So people may have prolonged QT, like this patient, which was described by Dr. Moss and Dr. Daubert in a case report in New England Journal in year 2000. So there is somebody with prolonged QT, and this QT here is definitely prolonged. And this person may develop this abnormal rhythm, which is this disorganized rhythm called torsade de pointes. And subsequently, there is this shock and discharge from the defibrillator, which kind of homogenizes electrical activity of the heart again, comes back to normal with normal rate. This is how this defibrillator works, and this is how those external defibrillator works. There are already number of years of research on the implanted cardiac defibrillators for many diseases, including long QT. And what is currently recommended, there are some recommendations who should be eventually qualified or considered for implanted defibrillator. And as you see over here, there is first of all cardiac arrest. So there is no question, if somebody had cardiac arrest and fortunately survived, these people should be implanted because the risk of subsequent event is very high, and there is so-called class 1 recommendation. ICD is highly recommended. If you speak about people who have recurrent syncope while on beta blocker, guidelines indicate that it could be useful. It's lower class, class 2A, but it's still to be consider here, whereas asymptomatic, not treated patients with beta blocker should not be indicated, as you see from this 2013 guidelines. What we know about ICD therapy in this patient and about the risk. Years ago, in 2003, we analyzed our cohort of 125 patients with ICDs, and we found that on average, they had like arrhythmic events about 4% per year if you average this over 17, over 4 years from our analysis. What was important at the time to look at, that we wanted to look at people whom I mentioned earlier, who had cardiac arrest, which should get immediate indication for ICD. And we also look at people, as we call them at that time, primary syncope on beta blockers. And that's this Kaplan-Meier curve, which is kind of way we graphically present the data. This is a time axis where you have number of years from the day of implant of an ICD, and you have scale of probability of arrhythmia in percentage pretty much. You see that at 6 years, both this group had about the same rate of 18–19%. So this indicates that probably this group of patients should be also considered for an ICD. Dr. Wojciech Beaton, who worked with us over a couple of years, he put together very nice analysis of people who do not have history of aborted cardiac arrest or cardiac arrest. So those for whom we may have more questions and hesitance whether to implant an ICD. And we came up with the kind of score which allows us to better risk stratify this patient. As you see, there are few factors which could be determined in patient: QTC duration, based on these three categories, prior syncope on beta blocker, LQT2, or people with more than one mutation, which Dr. Ackerman mentioned, that 5 to 10% of patients might have more than one mutation and they might be at higher risk. And even if you just look at risk of QTC, risk of ICD shock, depending on QTC, from this cohort of about 200 patients analyzing that paper, you see that the risk for people with QTC above 500, it should be above 500 here, is about 2, 3, 4 higher than those below. And this data allow us to eventually identify, based on some scoring, using these few variables, risk which could be better quantified. And also importantly, that some patients have recurrent shocks, not only one arrhythmia per life, but they may happen more than one over a period of time. And when Dr. Beaton looked at that from the standpoint of whether a score proposed consisting of these few variable works, as you see over here, those people who happen to have score 2, very long QT or LQT2 or combination of what I showed you on previous slide, they have very significantly higher risk of events. So this is something which our colleagues physician may use to help with the decision who will be prioritized first. Dr. Yunis, who just spoke a moment ago, he put together very nice analysis of sex-related differences in long QT syndrome in patients who were implanted with an ICD. And again, I'm using this so-called Kaplan-Meier curve with time to event. As you see over here, we have similar curve superimposing each other in males and females, although vast majority of implanted devices were in women, in females. As you heard already a couple of times today, female, especially above puberty, they have significantly higher risk than males. But despite the fact that there is the case, if somebody was qualified already, male or female, for an ICD using current indication, they have pretty much similar risk of events, as you see over time, appropriate so-called therapies. We also analyzed recently with Meng Wang, PhD student at our department, effect on mortality in long QT patients. And this analysis was including 3,000 patients in our registry when we look at effect of ICD on mortality. And there were 389 deaths in these 3,000 patients. And what we found that when we look at very sophisticated statistical using statistical approach, we found that ICD was associated with about 46% reduction after adjusting for all possible covariates and clinical presentation of patient with and without ICD. We were also interested, obviously, what's going on in people who are younger than age of 50, because obviously after age of 50, you may have more coronary disease, hypertension, and other factors which influence. And over here, the reduction in mortality found in this analysis was even more impressive, 71%. And when we confine this to just sudden cardiac death, was 78% reduction. So very encouraging data. We also look at specific indication subgroups. As I mentioned earlier, aborted cardiac arrest is the primary indication, and nobody has doubts that this ICD should be implanted. And 86% reduction was observed in 228 people who happened to have aborted cardiac arrest if they had an ICD. And if you speak about people who had syncope while on beta blocker, so we speak all the time that beta blocker is really mainstay of the treatment, but some people still develop arrhythmias while taking religiously beta blocker. So those people are at high risk, as we heard this today too, and those people also benefited a lot, 73% reduction. We also analyzed group which had syncope, not even starting yet beta blocker or not taking beta blocker, but having QTc above 500. And this group is obviously not that frequently implanted, but still these people, if they were compared, those with ICD versus no ICD, they had about 58% reduction. So this encourages us to be really more precise in terms of risk stratification and identifying high-risk people. And this should be done even further, as Dr. Goldenberg mentioned, with some specific genotype. But there are also some drawbacks of this therapy. There are so-called inappropriate therapies. What it means that this device delivers this shock for arrhythmia, which is not really life-threatening or for other reasons. And unfortunately, there is definitely relatively high risk of those inappropriate therapies. This Kaplan-Meier curve for males and females from Dr. Uni's paper shows you that there is very similar risk in males and females. And if you look here, it's about 34% at 15 years, it will be a little bit less than 10%, 10 years, but it's pretty high, similarly high to risk of appropriate therapy. So there is definitely room for improvement. So if you speak about inappropriate therapies, there are some technical issues related to electronics and system within defibrillator, which cause that there could be malfunction of an ICD, about T-wave oversensing, meaning that because of prolonged QT, this device counts these two waves of QRS and T waves as kind of two QRSs and delivers this shock unnecessarily. And there are some supraventricular arrhythmia from another chamber, upper chamber of the heart. So these are pretty much reasons for those inappropriate therapies. Some of them could be alleviated by improved programming. Some of them still require improvement in ICD technology, which is, of course, not perfect. So I would like to finish with saying that we have already data that ICD is really life-saving therapy, beneficial in well-selected high-risk patients with long QT. And we observe about 10-year risk in such high-risk patients of about 23%, And as you see on the slide, from this analysis of Dr. Meng Wang, we also look at inappropriate therapy, and we found exactly 23% at 10 years. So it would be very important to improve further ICD technology and conduct further research, which we are pursuing to really reduce the risk of inappropriate therapies and have this ratio of appropriate to inappropriate much better than 1-to-1 as I'm showing you. I'm stopping here, happy to take any questions or open discussion about this particular important field.
Thank you, Wojciech, for the great talk. I do see one question addressed to that, maybe to clarify the distinction between pacemaker and defibrillators, because there are some patients who do have pacemakers, and they were asking whether they should be continue with that or go to an ICD. So maybe clarify this distinction.
Yes, so there are some patients who do not require a defibrillator, but they require pacemaker because they represent a group of patients with a low heart rate. So low heart rate may predispose to prolonged QT and may predispose to higher risk of cardiac events in long QT patients. So in some patients, especially it was in 80s and 90s, those patients were more frequently implanted with pacemaker as precaution. And some of those patients were implanted because once they started taking beta blocker, which lowers heart rate, they had excessive response to this beta blocker, and they were benefiting from a little bit faster heart rate imposed by pacemaker. But these days, pacemakers alone are really rarely implanted, only in some bradycardic, meaning slow heart rate cases.
Okay. Going over the other questions.
Elon, could I ask Dr. Zareba a question?
Yeah, of course.
So Wojciech, you probably have been more intimately involved in device therapy for long QT than probably anybody living now after your mentor and our friend Arthur Moss. What's your own thoughts about the SICD device? I still have concerns about it having too high of an inappropriate shock rate in my long QT patients, especially the LQT2 patients that seem to have more dynamic T waves that go in and out of the SICD template. Are you seeing that? Do you share that? Or should I be thinking more favorably about the SICD than what my current bias is?
First of all, we have limited number of patients with SICD in our registry, and we don't have good data from our own sources to really further answer exactly the question you are raising. Yes, we are aware of the higher or high risk of inappropriate therapy with SICD. But as we know from some recent studies published by colleagues from the Netherlands, when they compare in long-term follow-up subcutaneous ICDs with transvenous ICDs, overall event rate, both inappropriate and appropriate, happen to be very similar. In terms of specifics for long QT, we were a little bit more worried also about long QT3 patients who happen to have these remote T waves, which are kind of like separated from QRS by prolonged ST segment with relatively high T wave amplitude, and that this will be more likely to cause this issue than LQT2, which are more likely to be low amplitude T wave. But again, I don't have hard data on that.
I tend to agree with Mike because if you look at the overall publication that compared subcutaneous to transvenous, we see that the overall event result, like you said, Wojciech, was similar, but the rate of inappropriate therapy was higher with the subcutaneous ICD. This may go down with a new algorithm, but the rate of device-related complications was lower with the subcutaneous ICD. So if you want to go for a younger patient, you need to weigh the risk for long-term implanted devices within the heart with infection on one hand, and the other hand, possibly, especially in long QT, the higher risk of inappropriate therapies. So it has to be more of a shared decision making in this population.
Yes, and there was a question I see about some lower or medium risk patients. I would like to stress that low risk patients should not be considered for an ICD. Only patients who are really at higher risk, and whether using risk model, which we propose with Dr. Beaton in that paper published in 2019, looking at some factors which are potentially easily accessible, or whether applying any newer different sex-specific risk stratifiers. We definitely recommend that such tools are used, but I would not consider low risk. This should be still patients which, based on our best judgment and science, will be at least moderate, high, or higher risk, who may not be straightforward qualifying based on just cardiac arrest.
Jeff, any comment?
Jeff, please.
Just to go back to the sub-QICD question. I have done a few selected ones with all of the above concerns. I do think since the latest round of high-pass filter that came out, it's been a little better. And I think that if someone had a collection of T-wave morphology tracings, like perhaps from a bunch of epinephrine challenges, the manufacturer might be able to simulate them and see how they do.
Very good point.
Before we move on to the next section, I'm going over some questions. There is a question about the risk calculator that I mentioned last year. Wojciech, you want to say a few words about the risk?
Yes, so we have this risk calculator being reviewed by one of the journals. And once, let's say, this review will be fully completed, we are planning to post it and publish it and post it on the website.
Another question is related to the postpartum period, how long it is. In our study, it was 9 months of risk. It may be low, but we identified this time period for a risk. And these are
I think that we touch on this question. I saw it earlier. I believe, you know, as I mentioned, our analysis was developed based on 9 months periods, but obviously this continuous beta blocker therapy, as Dr. Ackerman mentioned in LQT2, especially should be continued. It should not stop after 9 months.
And we're going to go over the questions later, and you're welcome also to, this program is going to be recorded and going to be accessible to everybody. But we do need to go to the next section, which is a panel discussion. Wojciech, you want to take this over?
Yes, so we will have also now contributions from Dr. David Huang and Dr. Vinokur with some interesting cases and some of their thoughts on long QT. So David, if you could, thank you.